Welcome to the PT and OT Connection podcast by Summit Professional Education, dedicated to helping PTs and OTs improve patient outcomes while earning continuing education credit. For information on earning CE credits for this podcast and satisfactory completion requirements for your state and profession, please go to summit-education.com or click the link of the course description in your podcast platform.
Hi, and welcome to the PT and OT Connection podcast by Summit Professional Education. My name is Nikki Dawson, and I'm a PT, and I'm going to be the host of today's podcast, helping them stay on their feet, looking at comprehensive falls management and our geriatric rehabilitation. I'm hoping that we can provide some information for you from the American Geriatric Society's fall guidelines, our APTA clinical guidance statement, and the new clinical guidance statement that came out from a nice world expert panel over the last year, and that we can get some information out to you that you can use pretty immediately in the clinic as a PT, PTA, OT, or CODA. We're going to be talking about falls demography and its impact on the economy and healthcare. It is a global crisis right now, and as PTs and OTs, we really play a critical role in helping to manage falls. We're going to spend most of the podcast looking at the comprehensive assessment of risk factors, because really that is the most important part of falls management, is really identifying the risk factors that our patients have. And then we will talk about documenting this falls risk as well as developing an individualized plan of care based on our assessment. And that's really the easy part, because, really what we know is after we do our evaluation, we treat what we find. So again, that's why we spend, a lot of time talking about falls management in the assessment phase. And this will be appropriate for both evaluating clinicians, and treating clinicians, because our treating clinicians spend most of the time with the patient. So there may be things that, don't illuminate during the initial assessment, and that come into light a little later, maybe at visit 3 or 4, or even a few weeks into, treatment. So, we have to have a good understanding, regardless of where we are in our plan of care, how to identify these risk factors. So there is a resource guide that will accompany this podcast. I'll refer to it some, but you might be driving or listening to this on a plane or, wherever where you don't have access to that. So it's not going to be crucial for you to be looking at that resource guide, but it does have, some visuals for you that might be helpful. I think initially, the most important thing for us to, again, talk about is, our role in comprehensive falls management. It was really interesting as I moved from outpatient, which is where I started my career, into skilled nursing. I really realized that falls do fall on us as rehab professionals, which I didn't really understand why that is. I remember a nurse once asking me, is Louise going to fall? And me responding, I don't know. Why are you asking me? And she's like, well, you're the PT. And I quickly realized there that, there's this urban legend that's out there about falls, that falls equals balance. And I'm hoping that one of the things that this podcast will help you do is understand that that's absolutely not true. There's so much more to falls than just balance. And so that's where, this comprehensive management really comes into play. And so our role, is usually in that strength, mobility, balance, but I would love for us to take a larger role when it comes to falls, because people kind of defer to us anyways. But we need to be able to look at more or either help guide the rest of the interdisciplinary team to help us identify these other risk factors. So we're definitely going to talk more about that. But again, I want you to listen to this podcast, either through the lens of being a leader of an interdisciplinary team, and being able to help that interdisciplinary team get this full assessment, or, as a solo practitioner that's going to look at the comprehensive risk factors on their own, which is totally fine, because oftentimes an outpatient, really you're doing this alone, or, if you're in a home care environment and you don't have a big team, that you're doing this alone. So again, listening to this through that lens. So let's start with, as we talk about falls demography and its economic impact, let's first define falls. What is it? And we think about, a few different places we can look, and the CDC defines a fall as a person descending abruptly due to the force of gravity and striking a surface at the same or lower level. So let's pull that apart a little bit and have an understanding of what are we talking about here. It really is, in, my view, an uncontrolled descent due to a loss of balance. So someone loses their balance, and they use a stepping strategy or even a reaching strategy to catch themselves on the wall. That's not really a fall. That's a loss of balance that was corrected. But sometimes you'll hear a patient say, I lost my balance, but I didn't fall because the wall was there, or the chair was there, or the bed was there. I landed on the recliner. So these are things that concern me, because it sounds like a very uncontrolled descent, right? That required external correction, either from that piece of furniture, from the wall, from their husband, from whomever. So by definition, that actually would be a fall. And so I don't tell you this so you can, pick on your patients or, berate them and really get them to admit that they fell. I think it's important because the number one risk factor for a fall is a previous fall. So if you have a patient who, had a fall within the last 12 months, or the last 6 months, then there's a really big concern that they're at high risk for another fall. Okay. So let's quickly talk about why patients don't tell us, though, that they fall. Let's think about that. I hear often, that the patients might be embarrassed, which is possible, but the number one reason that our patients don't tell us is because they're concerned about losing their independence. So what we know as we age, our triggers for anxiety change a little bit, and our triggers for worry. When we're younger, we worry about love and relationships and money and work, which is very true. However, when we age, our number one, trigger for worry is losing our independence. So that is why most often older adults aren't telling us that they fell, because they're concerned, that they might lose their independence. So here's what I want you to think about is, what do we do as a healthcare system when someone tells us that they fall? Think about that. Unfortunately, we strip away their independence oftentimes, right? We tell them that, they're now a safety risk and they're going to require 24-hour supervision, or, they need to move into an assisted living facility, or their daughter needs to live with them, or whatever. And so think about that. If, their worst fear is losing their independence, and that's exactly what we do, I kind of wouldn't tell us either, because it really is, it's their worst fear come true. And here's what I want you to also think about. I want to challenge you a little bit as we're going to talk is stripping their independence and, requiring them to have 24-hour supervision doesn't actually work. And if it worked, I'd be all for it. But if it worked, people that lived with their daughters, or people that lived in assisted livings, or people that had 24-hour caregivers wouldn't fall. And that's just, we all know that that's just inaccurate. And so how do we fix it? I've never really heard a healthcare professional say to a patient, I'm so sorry that you're falling. That must be really scary. Why don't we do a comprehensive assessment and figure out why you're falling? But that's the answer, guys. That's what we need to be doing. Is it's not their fault that they're falling. They're not doing wild and crazy things around their house. They're just getting up and going to the refrigerator, or they're getting up and going to the bathroom, or they're getting up and going to the mail. Because we do know that most falls, happen during their normal routine activities. And so, but what's happening, as we're going to talk about, is, there's multiple risk factors, that are coming together into a perfect storm to lead to that fall. And so we need to come at this a little bit differently. And again, as rehab providers, I'd like us to lead this charge because I think we spend a lot of time with the patients. I think caregivers and patients trust us. And I think we're in a really great position, to really make a big change here. Okay. So let's talk about, some of the facts here and what we see when it comes to falls. There are a lot of falls that are happening. 1 in 3 to 4 older adults fall every year. And that number really has been the same since the beginning of time, at least as I feel. So how do we move that number? Let's think about what's going on here, and how can we have a biggest impact when it comes to falls. I think there's 2 reasons, that this is happening. And one is that our healthcare system is pretty reactive, when it comes to falls. We wait for someone to fall before we intervene. We're not actually actively, pursuing a falls prevention. And I think, again, as rehab professionals, this is a place where we've always talked about getting involved in health promotion and prevention and things. And I think falls prevention is a really great place to start. And we'll talk about that here a little bit more, but falls do cost the healthcare system a lot of money. So as we talk about documentation, insurance companies will pay us if we've outlined someone is at risk for falls. Okay. So thinking about medical necessity, that's what Medicare requires, that we are able to justify as medical necessity and our skill. And I've just already told you that if someone's told you that they've fallen, they're at high risk for another fall. You've actually just justified medical necessity, because one of the criteria for medical necessity through Medicare and most of the Medicare affiliates, because they follow Medicare guidelines, is that you have to show that the patient is at risk for injury or illness. So they don't have to have already been hurt. They don't have to already, have bad stuff going on. They just have to be at risk. And we have a lot of different measures available to us that we'll talk about, that can help us identify that our patient's at risk. So we really just need to identify that. And then also, this number when it comes to falls isn't really changing much, because also the number of older adults that we have is growing. So, not only is the prevalence not changing, but we have the number of older adults exponentially rising, So if you look at, the one graph I have, it's really kind of gut-wrenching to think that in the next, 10 years, we're going to have 7 older adults die every hour from a fall. I just think that that's something that needs to be intervened upon, and we just need to start doing this better, as a healthcare system. So these facts are a little bit overwhelming, but I think if we can take a systematic approach, we really could have a really great impact. And again, as rehab professionals, I would love to see us take the lead here. Okay. So again, looking at the comprehensive management of falls, most falls are occurring during their normal routine activities. They're falling at home, they're falling in their yard, they're falling going to the grocery store, they're falling, they're not doing really unsafe, impulsive things. I hear us talk about that a little bit. And I don't think that necessarily they're truly impulsive, which is really a cognitive dysfunction. It's just that, they need to be performing their activities of daily living, and maybe their body is not up to snuff, which is again where we can come in as rehab professionals and make such a big difference. And we know that falls are, multifactorial, which again is why this comprehensive assessment is so crucial, is because when we look and we ask a patient, maybe, why did you fall? What happened? They oftentimes have no idea, right? They're just like, I don't know. I just kind of was standing there and then I wasn't. And it's because they don't necessarily know. Shoot, I could be watching them and they could fall and I really don't know what's happening. It's because oftentimes we have 2, 3, maybe even 4 different risk factors that kind of come together to cause that individual fall. And so really our job isn't necessarily to figure out what happened with that fall. It's to prevent the next one, but it would also be great if we can prevent the first one, through some of our assessments and some of our other things, because falls are common. they're predictable, but they are preventable. And it's really also important to talk about the fact that they're not a normal part of aging. So let's think about, how in the world do we even think about stopping this first fall? Again, it's about the prevention, right? So let's think about what tools we might have available to us, or, what evidence we might have available to us to allow us to step into fall prevention. So I'm not sure if you guys know this or not, but there is a best practice guideline out there by the American Geriatric Society, and it is reinforced by the new world guidelines that were just put out in 2022, that all older adults should be screened and or evaluated for a fall every year, at least. This isn't happening. Also, the American Physical Therapy Association, they, through the APTA Geriatrics, recommend all older adults have a physical therapy visit every year at minimum. So we have two things right there that allow us to get involved in patients who really otherwise wouldn't necessarily see us. And when we have these national organizations putting out these guidelines, that really gives us a lot of power, behind these recommendations that we make. So let's think about it. How do we get these people? It's not like we're going to be going door to door saying, let's talk about falls or let's talk about rehab. We have to figure out, where they are and where they're going, because they certainly aren't coming to us every year. But where are they going every year? One of the best things that has happened in recent years is the implementation of the Medicare wellness visit. So older adults are definitely, going to their primary care physicians or their geriatricians for their annual wellness visit, which is really, really great. So we might have an in here. So let's think about it. We certainly aren't going to be able to think that the physician is going to have time to do the things that we need done. However, what we can do is educate this physician on what we just talked about. The fact that older adults should have a fall risk screening and or assessment every year, that they should have a rehab visit every year. So we know that the physicians aren't going to have time to do these things, but as part of their annual wellness visit, is it possible that that can include a referral to us as rehab professionals so that we can see these patients, right? And then step 2 of the master plan is, once we have them, is to manage them. Instead of discharging our patients and just saying, like nails on a chalkboard to me is, I hope to never see you again, right? They're 87. Of course you're going to see them again. We're not sending them on their merry way and saying, good luck. We need to manage that patient based on their risk factors and based on their fall risk profile. So let's say that I have someone who looks great. They don't have a lot of risk factors. They're doing really well. I may not need to see that patient for another year, but if I have someone who has multiple risk factors and needs really close watch, I might choose to see them in 3 months, after they're done with their initial plan of care. I might want to follow up with them in 3 months. And this model is pretty normal in healthcare, because think about it. When you go to your physician, and maybe you had a sinus infection, or he or she started you on a new blood pressure medication, they're not like, I hope to never see you again, right? They say, let's follow up in 6 months, or let's follow up in a year. I'll see you at your next annual. We need to be doing the same thing with our patients. And instead of course, we're still going to write discharge summaries, but instead of saying we're discharging them, we're ending an episode of care. If they meet their goals and they do those things, we're going to end this episode of care. And then we're going to talk to them about when we want to see them again, rather than just sending them away. Because oftentimes I'll hear therapists say all the time, I knew they were going to fall. I gave them like 4 months. Then my response is, why didn't we follow up with them then in 3 months to help mitigate those risk factors that could have potentially popped up, in those months, and help keep that risk as low as possible? That's something that we can do. And you're just going to, you're going to talk about that in your discharge. So, I'm going to say patient has met all their goals. We're ending this episode of care. However, due to this risk factor, and this risk factor, I'm going to follow up with that patient again in 3 months, or I'm going to follow up with that patient again in 6 months. Or if my patient again looks good, I'm going to say I'm going to follow up with them again for their annual wellness, or their annual fall risk assessment, or their annual physical therapy visit next year. And then you're going to advise the patient to, call you if you have any troubles in between, then and now, of course. So I hope that makes sense. And this is something that, I do on a regular basis, and I have many colleagues, that follow this model, and physicians are actually very appreciative, because now as you talk to your physicians, they have an extra set of eagle eyes on this, pretty high risk and pretty complex patient. So it really comes down to having conversations and increased communication, with your physicians. And again, most of them are not going to have any trouble backing the things that you do and signing off on your plan of cares, because again, as with Medicare, we don't necessarily need a referral per se, but we do need them to sign on our plan of care. So, they have to have a good understanding about what you're going to be doing, with your patient. So what does this assessment look like that we're talking about? Let's first talk about the screening. The screening is really just 4 questions looking at their risk. So it's asking about an acute fall. It's asking whether or not they've had falls within the last year. It's asking if they're worried about falling, so a fear of falling or a lack of balance confidence. And it also asks, if they're having any balance or gait difficulties. So while we said that balance does not equal falls, if they're having those, they are certainly at a higher risk. So, if they answer yes to any of these questions, this screening, then we definitely need to move forward, because according to our guidelines, they are at high risk. Now, within the New World Organization's guidelines, anybody that actually lives in residential care doesn't even need a screening. It's assumed that they're already at high risk, and they should just move into a regularly intervaled assessment. So the screening isn't even necessary for those patients. So that's really the main difference in these new recommendations that I've seen, is really even saying people that live in skilled nursing, people that live in even ALF, they really are already classified as high risk. So therefore, these regular intervals and management of their falls is crucial. Okay. So talking about this assessment, I really like using the STEADY program from the CDC. So if you're not familiar with the STEADY program, I highly recommend that you look at their website. It's STEADI, so Stopping Elderly Accidents, Deaths, and Injuries. And it's really easy to find, because if you Google STEADY CDC, it's the first thing that's going to pop up. And what's interesting is this website, it's so rich. Many programs, end up kind of going away, but the STEADY program is actually growing on a regular basis. There's so many modules that have been added. The resources are regularly updated. It's really a great program. And they even have what's called a coordinated care plan. So it's aggregated a lot of the research that has come out in the last 6 or 7 years on the STEADY program, and it's organized it into an approach that as a clinician, you can take and implement this program into your facility. Talks about implementing and integrating it into your EMR system for documentation, talks about finding a champion kind of in multiple disciplines and getting a task force together, because that's going to be really important, as you're going to see as we go through some of these risk factors, that some of it is outside of our scope of practice to treat, right? We can still do the screening, but then we need help in managing those medical risk factors. And so being able to identify someone from the medical team, from the nursing team, pharmacy is crucial, the nursing assistants, all of those folks need to be part of the big plan because we need their help in implementing our ultimate plan of care based on the assessment that we do. So I really encourage you guys to go look at the CDC website for the STEADY program and really kind of tour yourself through the website. I will tell you, it's kind of a rabbit hole. I would start with the clinical resources and the patient and caregiver resources. That's where all the downloadable forms and brochures are that you can use during your assessment and during some of your patient education. And then heck, I even say use it for some marketing, because if you're going to be going to these physicians' offices and doing some education with them about fall prevention and your role in helping them manage falls, you can take some of the brochures with you with your contact information or your logo, and then that way patients that are sitting in the waiting room, are able to also educate themselves and advocate for themselves, when they go in and see their physician. Or, you can leave some at the senior center or, at the YMCA or different places, to really help some older adults gather information for themselves and again, be able to advocate for themselves. Okay. So the STEADY program has a very nice fall risk factors checklist. So when I'm doing a fall risk assessment, right now my area is mostly outpatient. I'd consider it outpatient. So, I'm faculty at the University of Central Florida in Orlando. And so I see patients through my lab most often. And so they're coming in from the community. And so, it's kind of considered more of an outpatient type setting. But when I have somebody coming in to do a fall risk assessment, the first thing I do is pull out my fall risk checklist, my STEADY checklist. And this is going to guide my entire assessment. And so what we're going to look at is, again, the fall's history. So we're going to do kind of that screening. And then associated with each of these, I may have an associated assessment tool that I might use. So if I ask my patient if they're worried about falling and they say yes, I'm going to check yes. And then I might choose to use a measure that really quantifies their fear of falling or that worry. And we'll talk about a few of those, here in a minute. I'll go through a few of the different, assessment tools that we might have available to us. Then past medical history. So again, these medical conditions, looking at comorbid status. So most of this, we're just screening. Again, I'm not able to treat their orthostatic hypotension or I'm not able to treat their depression. However, I'm able to look at those things and screen them. So for instance, if I'm concerned that a patient might be depressed or have depressive symptoms, I can screen that in the guise of fall risk because that's what the patient's here for. So I might use something like the Geriatric Depression Scale short form, which is a 15-item yes, no, and I might administer that. And here's the thing is I'm not diagnosing my patient with depression, but right on the bottom gives us some cutoff scores of what might be concerning of depressive symptoms. So if they score a 5, out of 15, that's concerning. If they score a 9 out of 15, that's really concerning. And then I'm going to be able to provide information to the physician, that I'm going to need some assistance in having that further assessed because that can be putting our patient at risk for falls. Okay. So we have, through the checklist, we're going to go through all of the different medical conditions, that might be causing issues. And we're going to check yes, no, and then make comments. Okay. And then we're going to go through into a medication review. So, when we're in doing home care or opening the Oasis or doing different things, we're very good as rehab professionals at doing what's called a medication reconciliation. So this is very different than that. A medication reconciliation is what medications are they taking? What medications should they be taking and do those match? Well, medication review for fall risk is taking that a step further, and we need to see if any of those medications that they're taking actually put them at risk for falls. And to help us do that, we have a nice resource called the Beers criteria. So the Beers criteria is from the American Geriatric Society, and what it does for us is it gives us a list and outlines medications that might be potentially inappropriate for use with older adults because of the high risk for adverse events. So these adverse events, there's really 4 different categories of adverse events, that I see when it comes to the Beers criteria. One is gastrointestinal issues like ulcers and GI bleeds. One is about metabolic issues through the liver and the kidneys. One is cognitive, dysfunction or impairment. And then the one of them is fall risk. And so, the Beers list outlines all of those medications for us that put people at risk. And some of them are listed here. And then again, I told you that the study program is growing. And one of the places that they've grown is in a program called Steady RX. So it has an entire training module for pharmacists. And so you're able to also go look at that just to educate yourself further, but they understand the high importance of a pharmacist and medications in managing fall risk. And they have a really good resource that's called the Community Fall Risk Checklist. And it's for pharmacists, and it lists all of the medications that are potentially concerning and asks the pharmacist to review the patient's med list to see if they're on any of these. So oftentimes, I'm not the one doing this medication review during my evaluation. I might be sending this list or the community checklist, the pharmacy checklist, over to their pharmacist. So this is why, when I said earlier, the task force or, the committee, that you have at your facility, a pharmacist has to be on it, because in an acute care setting, you have a pharmacist that's reviewing that patient's med list, and so are we able to ascertain whether or not any of those medications are putting that patient at a very high risk, and that can get communicated with the physician. And so again, medications are something that are really important to look at, because again, we might not be the ones looking at all of these things. It might be another member of the team, however, we have to really understand why all of these things are so important. Okay, so we're going to be looking at prescription, over-the-counter, and supplements. The Beers criteria really review mostly the prescription medications. However, all of the other medications, are really, really crucial as well. Okay. Now, looking at gait strength and balance, looking at physical performance, this is kind of our bread and butter. And so I think it's really important for us to do a deep dive, when it comes to this. Now, the study checklist has some recommended measures also in this domain. And I use some of them, but some of them, again, I kind of use a little bit deeper functional assessments in that I have to intervene on these. So I need a little bit more information sometimes than, the measures that are just recommended by the study checklist offer me. So I might do a couple more balance assessments. I might choose a different gait assessment. I might choose something different. And we'll also talk about fear of falling here too. But, when it comes to strength, one of the reasons that it's really important to look at strength is because as our older adults age, we have sarcopenia and dynapenia that come from that musculoskeletal and neuromuscular systems. So without any intervention, our patients will get weak. That is just a part of normal aging. And so there's nothing wrong with them. They haven't done anything wrong. But if they're not doing strength training on a regular basis, their strength will decline due to normal aging. So again, this is why that prevention is so important, because oftentimes, we're doing catastrophic management, when now they can't get out of a chair anymore. But if we would have been evaluating that patient on a regular basis, we would have been able to predict and intervene upon that potentially years before, they had any of those problems. And that's the big issue when it comes to these, annual assessments, is they have to be done because oftentimes they're going to catch many of these risk factors before they actually become a problem. So again, if our older adults aren't doing regular strength training as recommended by the American College of Sports Medicine or as recommended by the CDC, they will get weak with normative aging. And the way we evaluate strength, there's two measures for us. So general lower extremity strength, we're going to be looking at the chair stand test. And so we could either use the 5-time chair stand test or the 30-second chair stand test. Those are going to be our best measures. I use the 30-second chair stand test most frequently, and that's what's recommended by the study program. We also can look at the heel rise test because plantar flexor strength is really, really important when it comes to gait and balance. And so, looking at the heel rise test, being able to see if that power, is available to our patients, can really help talk to us about why they might have a shuffling gait pattern or, why they're not picking up their feet, because that power is so important because of sarcopenia and changes in the neuromuscular system. Okay. Now, when it comes to balance, balance is again, one of the most important parts of looking at this portion. But again, balance does not equal fall risk. I think this is so important to understand that there are multiple systematic reviews that are out there right now that really caution rehab professionals in using balance assessments to diagnose fall risk, because most of these measures have a very low diagnostic accuracy. And so how do we know that? We know that through two numbers that come with whatever cutoff score that we've assigned to that assessment. And those numbers are specificity and sensitivity. So if you've never heard of those, I'm going to talk about them here briefly because I think it's so important. Specificity helps us understand how good a test is at identifying someone at risk, okay? And sensitivity tells us how good that measure is at ruling that patient out for risk. And so let's say, one of the things we can talk about is the Tinetti, gait and balance. It's probably one of the most commonly used fall risk assessments that we have in rehab. And there's actually research that's emerging to tell us to stop using it because the specificity and sensitivity is so low. So, we have a cutoff score on that as of 19. 19 is the cutoff score that we're all told and that we're all given. And what we do is we make the assumption that that test is perfect and, that anyone who scores above a 19 is good and anyone who scores below a 19 isn't good. And unfortunately, that is not how you can read these tests, because the diagnostic accuracy of those tests is so important to understand. And we do that through specificity and sensitivity. And the specificity and sensitivity for the Tinetti is in the mid 60%. And here's what I want you to understand. What that means is that if someone, using this cutoff score of 19, if someone scores below a 19 and you say, yes, they're going to fall, you're only correct about 64% of the time. So again, it's not a perfect cutoff. And the other way is even a little scary too, is because, somebody scores above a 19 and you say, you're good, your balance is fine, you're not going to fall. Again, about 65% of the time you're correct, but 35% of the time you're incorrect. So you're telling, you're kind of ruling this person out as a fall risk, but you're doing that kind of, to me, at your own peril, because, a 65% specificity, 65% sensitivity in this case is really just too low to be able to say those things. So hopefully you guys can dive in a little bit more to specificity and sensitivity and really understand it. But I hope, that I was able to help you a little bit because, we don't have a lot of measures actually in rehab that do a great job at predicting fall risk, because what we have gait and balance measures, right, that are used to predict falls. And I've already told you that balance does not equal falls. The steady checklist is what we need to be using to ascertain someone's fall risk. Yeah, balance can help, but it's only one small piece of that puzzle, okay? So what we have available to us are some tests, like the 4-square step test. That's a measure of dynamic balance, and that actually has a pretty high specificity and sensitivity. We have our functional reach test, that has a cutoff score of 8 inches, and it has a specificity and sensitivity, again, that isn't too shabby. It's in the 70 and 80% range. And then we have something a little bit higher level for some of our higher level folks, is the Fullerton Advanced Balance Scale. And you can use the Tonetti, but again, use it for our lower level gait and balance measures, rather than truly using it for fall risk. So, you can, again, balance on the study checklist is just one check mark. It doesn't tell us everything. It's just going to be one of those things that tells us, do we need to intervene on balance? Is balance a risk factor? That's all I want us using these tests for, not taking that balance test and then using it to globally define whether or not somebody's a fall risk. We're using it as a piece of the puzzle. Okay. Same for gait and mobility. We have gait speed, which to me, and much of the research out there, is our single most important parameter of gait that we have available to us when we talk about health and function. There's a really great article by Stacy Fritz and Michelle Lusardi that call it the 6th vital sign, and there's multiple other articles that talk about the importance of identifying gait speed in trying to predict someone's changes in health and function. So looking at both comfortable and fast gait speed with something like the 4-meter walk test can be really helpful for us. We have our timed up and go. That does also have a cutoff score, and the specificity and sensitivity on that is about 87% for both. So that's not too bad. And then we have other measures like the dynamic gait index. And I would love to see more acute care therapists using the dynamic gait index, because it actually provides us some information about functional mobility and functional ambulation, how someone negotiates obstacles, how they're able to step over obstacles, how they're able to turn, how they're able to navigate their speed and modulate their speed, during normal ambulation. These are things that are really much more important than just saying that someone can walk 250 feet, which really there's no research to support the use of distance in anything we do. It's all about speed. It's all about the negotiation, in their environment. It's about divided attention. It's about lots of other things other than distance. Distance really doesn't matter, and I don't use it in any of my evals. I hear a lot of people say that we have to use distance because that's what case managers are telling us that we have to do, and I challenge you guys a little bit because, we've kind of already said that, medical necessity is really what you need to identify, and if you're able to use these measures to outline medical necessity, then the fact that they can walk 250 feet is actually irrelevant. And I think that's important to advocate for your patient, because I'll oftentimes, say that to a case manager when they tell me that, if someone can walk more than 250 feet, they can't go to rehab, and I'll challenge that case manager and I'll just say, can you show me, where in the patient's insurance benefits it says that? Because we're telling a patient that they don't have access to benefits that they're entitled to, by false information, and that's just not okay. I'll also ask the case manager, can you show me in the admissions criteria for the facility where it says that if they can walk 250 feet, they can't go there? And, it's just not there. This is just another one of those kind of urban legends, if you will, that have kind of come through. There's nowhere in the Medicare manual does it talk about distance, not even when it comes to home care. When you look up the definition of homebound, it really is more about effort. So homebound, the definition of homebound is that someone cannot leave their home without considerable and taxing effort. So again, it's nothing about distance. And I would argue that if someone's gait speed was very slow or that their strength was very low, that would make them ambulate with considerable and taxing effort. And so you don't need the distance in there to be able to justify that medical necessity or to be able to justify homebound status. So I think these are things that are really important for us to understand as rehab professionals, is really, what do we need to justify in order to get our patient kind of moving forward with their benefits? And it really is mostly about medical necessity. Most payers, that we will deal with in the geriatric community do follow Medicare guidelines. Some don't. And so you just have to be clear. There's some that it's 20 visits, no matter what. And so it's really important to really understand what that insurance company needs from you to be able to get that patient the benefits that they need. So I encourage you guys to talk to, your admissions people, your front desk, your case managers, and really, not just harp on this distance, but really understand that medical necessity. Okay. Then we also have, as we kind of move down the study checklist, is we have vision through, so different somatosensory issues. I also will add sensation, to be concerned if there's any peripheral neuropathies, that can be important when it comes to balance as well, and other, issues as related to gait and falls. So looking at their vision, whether or not using a Snellen chart for visual acuity, or oftentimes I'll just ask the patient if, they're having any visual impairments that are affecting their ability to function. Because research tells us that useful field of vision, and you can measure that with a confrontation test or other computerized generated field of vision, is actually the best predictor of falls. And it's not necessarily visual acuity. And then also, depth perception or contrast sensitivity are really important with just overall function. So sometimes I'll just ask whether or not they're having any deficits. Because again, I'm not necessarily intervening upon that. What my goal is here is to screen it and to see if it needs further evaluation for fall risk. So if I have a patient who says, yes, I'm having some visual deficits, then I'm going to refer that back to the physician. And so they can have conversations with their physician and maybe get those visual impairments rectified. Okay. And then I also add to the study checklist, a home assessment or an environmental assessment if I can. There's sometimes where you're not able to do that because of your setting, but of course, if you're in home care, very easy to do. The study program does have a home safety checklist as one of its brochures or one of its kind of, handouts. So even if you're an outpatient or in acute care or even in skilled nursing, if you can't go do a home evaluation, you can provide some education to the patient and or their caregiver about environmental assessment and have them, go back and maybe look at some things or take some pictures for you or, so you might be able to help make that home environment a little bit safer. And sometimes it's difficult because sometimes patients, don't want modifications to their home. And so I think, you just have to decide, about this person environment fit. We either need to change the environment or we need to change the person. So yeah, if they don't want to pick up their throw rugs, I'm not always married to that, because what I hopefully can actually do is make them stronger and make their mobility better to where they can navigate that throw rug instead of us having to pick it up. And so my goal might be, if they have a lot of throw rugs, to do a lot of stepping and a lot of obstacle negotiation and a lot of different things to help them navigate their environment. So in that case, I'm going to try to bring the person up to match the environment rather than bring down the environment to match the person. It really is all about that person environment fit or that PE fit, understanding that environment. Okay. So that's the study checklist. And so now as we kind of move into our documentation talking about this, what we got to do is easily make all the yeses, no, as we move into our documentation and our interventions. But what I need to do is identify all the risk factors. So what are the risk factors? And I need to quantify them. So for instance, if we did a 30-second chair stand test, I need to be able to say that they scored a 4 on the 30-second chair stand test, but for whoever's reading that, I need to say, what does that mean? So I might just put in parentheses that the age and gender norm is 11 to 15. So that person can really see that there's some weakness there, or on the functional reach, I already told you that a cutoff score for that is 8 inches. So if my patient only scores 3 inches, I can say that that's much less than the fall risk cutoff of 8, but it's also much less than the age and gender norm for, my 67-year-old male of 14.9 inches. And so I'm now able to tell this story about my patient and their deficits. I'm going to do the same for, mobility things. So if my patient scored, a 10 on the geriatric depression scale, I'm going to say anything greater than a 9 is a significant concern, for depressive symptoms and fall risk. And so that needs to be evaluated. Okay. And then I'm going to talk to the patient about this, of course. And then anything that is outside of my scope of practice, I'm going to be sure to alert the physician and send that patient back to their physician. And so in the resources on slides 9 and 10, I gave you guys a little wording that I use. I make my typical assessment, that says, that the patient was referred to me and I use the ICF model to outline the health condition, the impairments, the activity limitations, and the participation restrictions, which is what Medicare wants us to do. So I tell that story. And again, I tell that story using objective data that I just collected, through my assessment. And then I also add a second part that says, as part of this comprehensive fall risk assessment, I found some other things that I think might be beneficial for you, and I wanted to alert you of those. And that's where I'm going to put any of the medical issues, that I found. So maybe vision, orthostatic hypotension, some decreases in their sensation, those kinds of different things I'm going to talk about, at that point. And then I'm going to let the patient know that I want them to go back and see their physician. And I'm going to also call their physician and let their physician know that I'm sending them back, because I don't want that physician to be irritated, that they just sent us a patient and we're sending them right back. And we need them to know why. Is that we need their help, that we've identified these issues, during our comprehensive fall risk assessment, and we really need their help to bring down and reduce the risk in some of these medical issues that are really outside of our scope of practice. Okay. So let's talk about that. When we talk about the clinical guidance statement that was put out by the physical therapy, by APTA. Now there's an updated one that's coming, within the next year or so. So look for that, but this is the one that we have available to us right now. And then also I have in your resources the algorithm from the study program. It's not the most recent one, because the most recent one, it's great and it says very similar things. It's just not as aesthetically pleasing. So I keep the old one in my packets because I just like it better. And the nice thing is the algorithm from the study program and the clinical guidance statement from physical therapy actually match. So it really is nice what it says. So when we're thinking about, bringing forward our interventions, it's talking about this multi-component intervention based on the evaluative findings. So again, this is why we spent so much time looking at that assessment, is because now it becomes easy. You treat what you find. You take all those yeses and you try to make them no. And we're going to do that together, as an interdisciplinary team. So we're going to conduct that multifactorial assessment, which we did. And then anything that's outside of our scope of practice, we're referring out. Okay. And then anything that's within our scope of practice, we're going to go ahead and treat. That's really what these clinical guidance statements are saying is, nobody can really answer. I get lots of people, that will ask me questions about, what's the best way for what were the best exercises for my mom because she's falling. it's not the right question, because here's the problem is I don't know that exercises are what your mom needs without doing a comprehensive fall assessment. Because what if it's a medication? What if she's on 6 medications that are on Beer's criteria for fall risk? What if she has orthostatic hypotension? Because guess what, guys? I can make her balance and gait the best ever, but if she has a syncopal episode, she's going down. What if it's a vision issue? So I had this once where, it was a guy was in his early 60s, and he came to our lab and he looked like he just went 10 rounds with Rocky Balboa, and he was falling 3 times a week. Right. And so sitting and talking to him, I didn't even need to do any assessments to know that it was a vision issue. I mean, of course I did. I went through the whole study checklist. I went through the whole checklist, and we did lots of high level gait, balance, strength, all of the fun stuff. But what happened was he just had eye surgery, and his eye surgeon made one eye nearsighted and one eye farsighted, which sometimes isn't an issue, but for this gentleman, his depth perception was off. And so what was happening is he was tripping over anything that was less than about a half-inch threshold because he couldn't see it. So his latest, issue was he was leaving a restaurant and going outside. There was just a little teensy-weensy step down, and he didn't see it. So he missed it and face planted on the concrete. So this has nothing to do with rehab. I was able to give him some compensatory strategies, like, holding the threshold as he's going through it, but his son's recommendation was that he needs a cane because his balance is bad. And I told him absolutely not, because now all you're going to do is impale yourself, right, with the cane, because his balance was perfect. He actually scored a perfect score on the Fullerton Advanced Balance Scale. And as you guys go and look at that, you're going to be able to see that that's a very high level balance test. And so for folks that can to do that, it's really not the issue. For him, it was about going back to his eye surgeon and having some conversations about tweaking his vision a little bit, maybe with some corrective lenses or, whatever needed to happen, but needed to fix that. Okay. So that's why I can't tell you what the best way to fix your falls are until I do a comprehensive fall risk assessment. So hopefully, from the podcast, you guys have taken that, that really this comprehensive assessment is super important before we move into any intervention. And these interventions are going to, again, look at medications. It's going to be looking at these medical comorbidities. It's going to be looking at potentially vision, looking at some environmental modifications. So there's some really fun emerging technology like smart home technology and other things that can really help individuals with their supervision, with their fall risk, with other things. So I encourage you guys to find out who's doing, some of that smart home tech in your area and maybe do an in-service at your facility. Because there's some really cool stuff out there and it's changing every day. And then there's exercise, right? There's balance and agility training and our strength and power training. So when we talk about exercise, I think the most important thing for us to do is, go back to the basics. What do we know about exercise prescription and exercise management in our older adults? And what we know is when it comes to exercise physiology and exercise prescription, our older adults are really no different than our younger adults or even our athletes. And so we need to look at our exercise science principles and really be able to prescribe exercise at a high enough level. There's some research that's emerging in geriatric rehab is that we're grossly underdosing, our older adults when it comes to exercise. And so, I get people that will say, but Nikki, I'm so afraid that, I'm going to hurt them. I argue that you're hurting them by not pushing them hard enough. And so again, if you're able to follow the exercise science principles during your exercise prescription, you're not going to hurt them because you're logically progressing them. And so there's really a couple resources that are really great to have available. The American College of Sports Medicine's exercise guidelines for older adults, those are from 2013. We have the International Conference on Frailty and Sarcopenia Research, their exercise guidelines that came out in July of 2021, and those explicitly talk about power. Then we also have, the American College of Sports Medicine CDD-4 recommendations, and what that stands for is their chronic disease and disability recommendations, the 4th edition. And they do a really great job of going through various health conditions and talking about how to modify, based on that health condition. And oftentimes they're not very different when it comes to our standard ACSM guidelines. In strength and balance. Usually strength and balance remain the same. It's really the aerobic training that gets modified for the CDD-4 recommendations. And our aerobic training really isn't as important in our fall risk as our strength and balance training is. So oftentimes following, our exercise science guidelines for strength and balance training. And we're going to use the physical stress theory, that tells us that we must overload that tissue up to a moderate intensity and efforts to, really change any therapeutic adaptation. Also, our principle of specificity. So this is where the power comes in. If we're trying to combat sarcopenia, which differentially affects our type 2 muscle fibers, our fast twitch muscle fibers, to do that, we have to include power training, into our exercise programs. And I would argue agility training too, for that speed component, that reaction time component. So we really need to be doing task specificity. So large, functional training that include speed and agility and strength and power, to combat fall risk. So hopefully, this was helpful for you guys in putting together, how to manage fall risk, in looking at things comprehensively, referring out things that are outside of our scope of practice, and then really honing in on the things that are within our scope of practice, particularly exercise management through, strength and power training, and then balance and agility training. So the references for this are listed in the resource guide, and I encourage you guys to reach out. My email is here on the last slide with any questions, and I really thank you very much for listening, and let's go out and really make a difference when it comes to falls. Thanks so much. Bye-bye.
Thank you for listening to the PT and OT Connection podcast by Summit Professional Education. To view accreditation information for your state and profession and access completion requirements to receive a certificate for completing this course, please visit summit-education.com or click the link in the course description in your podcast platform.